Welcome. My name is Dr. Matthew Bramlett. I'm a pediatric cardiologist at the Children's Hospital of Illinois and the University of Illinois. And uh, this is sort of the introduction to cardiology. And this first segment here is just to kind of prepare you for what you're getting ready to run through. You can see a bunch of the different diagrams we're going to be using. I have a few reference images as well. And I have our heart here. I would encourage you to familiarize yourself with how to pause this lecture so that you can take those moments whenever I'm running through everything, which will be it's going to be a lot of condensed information. So you're going to want to make sure you can pause not only on the control panel, but also on your controller as well. And take the moment to be able to dive through and follow along at this pace. It also is helpful if you familiarize yourself with how you can adjust the transparency of the model as well, because you may find that the ability to pause and quickly evaluate that will allow you to get through some of these diagrams. Many of these diagrams were hand drawn, and so if you find that it's hard to read or understand, you can always rewind me to hear what I'm saying about it, but you can also change the size to see if that may help. As far as the content that we're going to be reviewing, I'm going to break this down to 6 different components. One being identifying basic cardiac anatomy. The second is getting into cellular function of cardiac muscle cells, really describing contractility. Describing the phases of cardiac action, potential, and conduction as the third one. Explaining cardiac output as a function of heart rate and stroke volume. Then identifying normal cardiac pressures and an impact of pathophysiology, and then saturations and impact of pathophysiology. This is, I'm going to be running through a lot of information. This is focused around the idea that this is sort of from a clinical perspective, baseline information that helps you to sort of build on that. This is me over here, the big doofus standing right there. I think I've made him a little taller than I actually am as well. So anyway, let's hop into it. Following each of the individual concept lectures, you're going to find a series of tasks to work through. You need to make sure that you're answering the multiple choice question until you understand and get it right. And you can always hop right back into the previous lecture where the answer most certainly, hopefully, will have been reviewed. Thank you very much. Good luck. All right. First step here is to review cardiac anatomy. And for reference, I'm starting out here where you can see a chest x-ray with the heart behind it here. And what we're going to do is run through the anatomy in a way that combines both the diagrammatic representation of it with the real thing. And so blood returns from the body through the inferior vena cava and from the head through the superior vena cava to the right atrium, goes across the tricuspid valve. There are 3 valve leaflets that make up the tricuspid valve into the right ventricle, out the right ventricle to the pulmonary artery, where it is then picks up oxygen in the lungs and returns through 4 pulmonary veins to the left atrium across the mitral valve. The mitral valve has 2 leaflets here. One forms sort of a curtain between the inflow and outflow of the left ventricle. And then from the left ventricle, the blood pumps out the aorta to the body, where it goes through the head and neck vessels to the upper body, and then down through the thoracic aorta to the lower part of the body. These are the atria, left and right atria, and these are the ventricles. So these are the atrioventricular valves here, and these are the semilunar valves between the ventricles and the great arteries. When we review the anatomy here, I have several different I have several different annuli. So the annulus is the location where the valves sit. And so I'm going to park these here just so you have a sort of a point of reference for each one of the valve annuli, kind of pointing them right at them. And so this is the tricuspid valve. The blue or the green arrow here is the pulmonary valve. The mitral valve is here with this blue arrow, and then the aortic valve is here. And so we're going to start and run through the anatomy like this. Here is, and I'm going to run through it in the exact same manner here. SVC, IVC, superior and inferior vena cava, come into the right atrium, which is here. And again, I'm going to encourage you at any point in time to pause and make sure you can, play this back. From there, it goes across the tricuspid valve. So I'm going to kind of come here. So here you can see the tricuspid valve and how it pulls into the right ventricle. One of the things you'll notice is that the inflow of the tricuspid, there's this big chunk of muscle between it and the pulmonary valve. You'll have to get up in there to see that. Whereas in the left ventricle, the blood comes straight in and straight out. And that's where that anterior leaflet of the mitral valve forms that curtain. So picking up where we left off, this is the right ventricle out to the pulmonary arteries. And you can see here how the pulmonary arteries branch to the right and the left before returning into the left atrium. And remember how I said there are four pulmonary veins? I'm cutting right through it so you can see the left upper, left lower, right upper pulmonary veins into the left atrium before it comes down into the left ventricle here. And from there goes out the aorta. And so you can see how the blood goes up and then down and around. I'll cover this later, but the conduction system includes the sinoatrial node here, AV node, and then it branches to the bundle of His into the branches of the right and left ventricle. Additionally, we have the coronary arteries. Those can actually be best seen if I make them a little more transparent. And so you have the right coronary artery, which wraps around in the atrioventricular groove, and you have the left coronary artery, which goes to the left side of the heart to give the left anterior descending, which runs in the in the interventricular groove between the two ventricles, and the circumflex, which comes around here in the atrioventricular groove. There you go. Good luck. All right, now we're going to discuss muscle types as well as contractility and how things begin. So, the way muscle works is you have a bunch of cells grouped together that contract and squeeze. And so, skeletal muscle, you can see here how it's aligned longitudinally, and it really has the greatest like single directional longitudinal force. Smooth muscle is, and it's voluntarily controlled. Smooth muscle is involuntary, as is cardiac. Smooth muscle doesn't have the same organization, and it's more just kind of the whole thing as a whole works together. Cardiac muscle is designed, if you think about it, whenever the heart squeezes here, for example, you can see how this overlays here. The purpose of the cardiac muscle is to squeeze circumferentially around. And so that's why you kind of notice that it's not as directional, it's more kind of a web like. And these are intercalated discs, these components here that allow rapid propagation of an action potential between cells, whereas skeletal muscle is innervated uh, with nerves. This is more because it's involuntary, it's got to be able to communicate, and we'll kind of get into some of those details. If I blow up this and kind of cross-sectionalize it here, what we find the components of the cell include the nucleus, a ton of mitochondria, but it's the contractile fibers that run down through here. And these fibers are essentially heavy myosin chains and the more thin actin. And what they do is they kind of pull on each other, which I'll describe here. But whenever you're looking, the striations that are typically described in skeletal and cardiac is this appearance of these thick components as they overlap and how it kind of creates the striations here. And these are the sarcomere, these are just different definitions of those individual components. Getting into the conformational change that can occur in the muscle cell, essentially what is going on is you have these two different actin and myosin uh, components that sit right next to each other. And what occurs, for example, if I've got my actin here and my myosin here, is whenever the myosin heads want to attach here, but there are things that prevent it, all the different troponins. The inhibitor here prevents these heads from attaching. Troponin C, however, whenever calcium sort of floods through and gets all in the cell intracellularly, in throughout all of here, troponin C is activated, which essentially allows the myosin head to bind up onto this, and its natural motion is to contract. And what happens is the actin and myosin, when it's contracting, pull together, and you can see how if all of those things are contracting, you get this shortening of the cell. And when they work in conjunction, that's when you get a contractile element. So how does calcium get in? And there's the ion channel associated with calcium is very complex, and the purpose here is to really go through the concepts. I've got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, which correlate to the diagrams here. What you need to know, though, is that an action potential comes down through the cells, through the intercalated discs, and triggers all of the different ion channels and the sequence of events that flood this intracellular region with calcium that then binds onto all of these. You get contraction when the calcium comes in, and then as it's absorbed back out, the calcium leaves and you get relaxation. And so the sodium potassium ATPase pump up here is what keeps this thing in a state of more negative on the inside of the cell compared to the moment when all of the calcium and sodium floods in. This is definitely a lot to take in, so make sure you spend some time on it. But you can see how the volume of calcium relates to the force of contraction. So now we're going to be discussing the phases of the action potential. And when we say action potential, it's important to understand that because of this pump is pumping out 3 sodium for every 2 potassium, we're creating a gradient between the intracellular and extracellular fluid that gives a relative membrane potential or difference between the two of about -90. And so that's represented here on this graph. This is sort of the baseline state because of that sodium potassium pump. Whenever you get this the action potential, or essentially um, enough of a flood of change so that there's some a positive trend on the inside, it can trigger these fast sodium channels, which dramatically open and everything floods in. You get this switch from -90 to a +20. And you can see that here. What's different between a cardiac cell and a nervous cell is nervous kind of comes right back down. Whereas cardiac, because we allow sodium channels to open, we're allowing this to continue and maintain um, that level of contraction, or the different membrane potential to be maintained, which allows for a chance for all the calcium to actually flood in and take an action. From there, so you have phase 0 as the sodium channels, they close. Calcium, which is more of the slow, and then the potassium is how things start to um, repolarize or from the component. From there, I want to describe what is a pacemaker cell. And so when you can imagine, with all the different channels and pumps that are going on the cell membrane, if you have a slightly different setup where there's maybe a constant leak, what you'll find is in some cells you never get to that -90. And that's what happens in pacemaker cells, such as the sinus node, the AV node, which sinus node is up here, AV node is here. They're constantly leaking, which means there's this intrinsic rate that whenever it hits about -40, that's when everything opens and you just can't stop it, and you get an action. And then it comes back down, but because of that leakiness and the different channel types, you get this repeating element. And this is your heart rate. So your sinus node here, up here, controls your heart rate. So the sympathetic system will, so your fight and flight response. Your parasympathetic system, or vagus nerve, is the opposite. It's how it's going to slow things down. The innervation of the heart, if the sympathetic system drives it, you get increased heart rate, stroke volume, contractility, everything. And the opposite is true of the vagus nerve. Same thing for chemical reactions, and what the like adrenaline can increase these things. And what's occurring in those scenarios is it's just altering the activity of these different channels that allow the how fast all of this to occur. So, and briefly, an EKG is the skin. What happens on the skin? It is just purely a representation of the reflected action potential going on inside the heart to the surface of the skin. And as a result, what we get with those scenarios is where'd it go? What we get is, as the atria contract, the combined muscular contraction we can detect on the skin, which is a P wave. When the ventricles all contract, because that's the biggest chunk of muscle, we get this large deflection here. This spike represents ventricular conduction, and then the T wave is actually everything relaxing and going back down. We don't see the atrial relaxation because it's buried, but this is a ventricular relaxation, which, because relaxation is spread out a little more, that's why it's not if everything relaxed at the exact same time, we would get another spike here. Those are some of the key components. You'll also notice these are intrinsic rates. This is a reflection of the pacemaker capability of each region within the heart.